Hello again. This is Dr. Alkamas. For people who don't know me, I am Professor Emeritus at the Ohio State University. Today we are going to continue or proceed with the talk on transplantation. So, the topic that will be discussed briefly will be transplant patient and COVID-19, and most likely will limit the talk to a kidney transplant patient. Disclaimer, I certainly have no conflict of interest, and I don't have any grants from the companies that I will mention. About a year ago, we were really quite shocked and confused. And I'm not talking about one individual or one program or one hospital. I'm talking the entire, basically the entire universe. But speaking about the transplant, we didn't really know. It's a new virus, a scary scene. People are dying. Civilizations are uncovered. The humans are dying all over the place, and economies have been destroyed. Economies of individuals as well as probably countries. And at that time, there was no difference whether you're living in a village somewhere in an unknown place or you're living in New York. Life came to kind of a stagnant situation. You go to work, you come home, you're wearing a mask, you're reading, you exercise at home if you are really good and disciplined individual and you care about your health. And if you are old enough like me, you probably ask a family member or a friend or somebody who's young to help you with the grocery. And that became our routine. However, there was another side of the story, that science ran with the speed of light. Publication became all over the place, a speedy track, research speed, and probably the review process was so fast, and some of it may not be even complete. But in any case, new updates are every day. And what you learn today may become obsolete in a week. And a lot of progress have been made during the COVID season. The surgical cases in most of the hospitals in the United States are looked at and divided into different tiers, and the transplant was in tier 3B, similar to the trauma or cardiac patients with symptoms, or a limb-threatening vascular surgery situation, and so on. However, ourselves, we were not really sure with what's going on, so we got together and divided ourselves into really what we need to do. So we have elective surgery. We had to postpone according to policy in the different tiers. We have emergency surgery. We continue to do, and we'll talk a little bit in more details later. We have clinics, so we need to switch the situation or what to do with the clinics, and most of them really became telemedicine, because we're trying to protect humans. So we're trying to protect the staff, protect our patients, protect the visitors, protect the equipment, and therefore most of the clinics became like telemedicine unless it's really needed to see the patient. And the elective surgery were postponed. And it became clear from the literature that our patients, whether they are pre-transplant or post-transplant, fell in the high-risk group. Almost most of the kidney transplant patients have high blood pressure. About a quarter of them, or maybe a third of them, have diabetes. Overweight and the metabolic syndrome is very common among our patients. And of course, after the transplant, it doesn't get any better really. Same issues, and you add to them more diabetes, immunosuppressed patients. When you read the literature, you realize that the transplant patients are high-risk group, among the high-risk group. And is it really because of the transplant and immunosuppression, or is it because of the comorbid conditions, or both? At first, really, we didn't know. We know that the patients are more vulnerable to the COVID and the severity of COVID illness. And one of the earliest reports came from Montefiore Hospital in New York, where they looked at 36 kidney transplant patients who were admitted with COVID-19. And the median follow-up was about 21 days, anyway, between 14 to 28 days. Out of those 36, 10 died, that giving you a rate of 28%. And among the people who were intubated and admitted to the ICU, there were 11 of them, 7 died, so that's 64%. And the majority of them had high blood pressure, and the majority of them had diabetes. So, it's a high-risk situation. And then when you add to it another report that showed a little bit wider group of patients, about 100 of them, and 43% developed severe disease within several days. 26% died as a result of COVID-19. Compared them to a similar cohort who had no transplant, but similar morbid and comorbid situation, they found that they both have similar morbidity and mortality. So they concluded that maybe the immunosuppression didn't really add much to the risk factors. Maybe the problem was mostly the comorbid and the chronic condition that the transplantations have, and resulted in a high fatality rate. Europe showed the same thing. This study from Jaeger and colleagues, they found that the mortality due to COVID-19 was 20% in the dialysis patients, and again 19.9 or 20% in the kidney transplant patients. So it's really very similar. And therefore, in our hospital, we decided to use PCR for the donor, PCR for the recipient, and temporarily the living donors were put at hold. We stopped it for a period of time. And the situation continued until we felt a little bit better, and then we opened the living donor program. The patients were admitted to a special COVID unit, and young doctors were rounding on them. Aspirin, as part of our transplant protocol, was continued. Steroids were continued, but the rest of the protocol is run by or controlled by the ICU people, ID and intensivists together. So in the following slides, I am going to switch gears and try to make it in a format of a question and answer. Those are really real questions I faced. Real questions I faced over time. And for example, the first one: can I donate my kidney to my brother during COVID-19 pandemic? And the answer is yes, if you have the proper equipment and the proper facility, proper ICU and proper PPE, yes, you can. And of course, condition that you are tested and your brother are tested and both of you don't have COVID-19? Can I receive a kidney from my brother during the COVID-19 pandemic? And the answer is the same, really. The answer is the same as for the first one for the donor. If there is adequate healthcare situation and equipment and so on. How about if the brother has COVID-19 and recovered? We waited a really longer period, about 2 months, 3 months, and so on. There's a study from India, from Acute and EOL, and they looked at donors who had mild to moderate symptoms, 31 cases, 100% survival, 6% of acute rejection rate, and so it looks it's safe, to wait some time. However, if you have received a kidney 2 years ago, should you change your medication? The answer is really no. There are no studies or reports that recommend changing maintenance medication. But of course, you want to continue the proper precautions, social distancing, mask, and hygiene, because there is no evidence to change the medicine and to change any of your outpatient care. Yes, the clinic visit have been modified, mostly telemedicine. And anytime we dealt with the transplant patient during the COVID season, or even for other situations, we always remember that diabetes, high blood pressure, older, and cardiovascular issues are very common among such patients. So we always take that in consideration. And if it happened that your patient developed COVID-19 with mild symptoms, of course, probably the first question you want to know what mild symptoms means. Either no symptoms or mild aches, loss of smell, loss of taste, no breathing issues. In this situation, yeah, you certainly mild. Moderate symptoms, we look at the saturation if it's 94 or less, and anything more than that, and pneumonia and so on, we consider it moderate to severe. And those patients I'll tell you what we do. So for the mild symptoms, we just treat them at home. You may consider stopping the anti-metabolite for some time. You may consider cutting the calcineurin inhibitors, tacrolimus or cyclosporin, to half the dose. And you allow the treatment of the symptoms and according to the protocol. If it is moderate, we really err on a different way. So moderate symptoms, where there is a little bit of fever or some pneumonia on the CT or chest X-ray, then the situation is different. And for the transplant patients, we did not treat them at home. We admitted them, and they were taken care of by the specialists. We continued the steroids, and we continued the protocol. And if the patient is doing well, should we give that patient the COVID-19 vaccine? The question is really a serious one, and we actually talk about it on a daily basis. And should the transplant patient be vaccinated? Because we know that the viral injury to the kidney and the angiotensin receptors and so on, and we know the inflammation is uncontrolled sometimes, and activation of the coagulation and complement cascade is common, and the transplant patient may shed the virus longer. The majority of people felt, we probably should really consider consider vaccination. Unfortunately, they were not used in phase 3 studies. But the ASTS, which is the American Society of Transplant Surgery, recommended to vaccinate the transplant patients. Now we come to when. We usually wait about 2, 3, 4 months after the transplant, and then you vaccinate them to give them time that their body will mount and their B cells will mount the capability to generate antibodies. On the average, 2 to 3 months in most of the programs. What type of vaccine should I get? Currently in the United States, there are 3 vaccines that have been approved. One of them, Johnson & Johnson, is adenovirus as a vector and similar to the AstraZeneca in UK. At this point, the STS felt that historically we have not recommended a live viral vector vaccine for transplant patients that take immunosuppression, and maybe also for the waitlist patients, because they really considered immunocompromised and they may have difficulty clearing the viral vector, as you see here in the guidelines from the STS. So therefore, we try to avoid those vaccines unless the recommendation changed later on. On the other hand, with the messenger RNA vaccines that are made by Pfizer and Moderna, appear to be the correct vaccine to give to the transplant patients. I think I'm done. I really appreciate your listening, and if you have time, please click on subscribe or leave a comment or a question. I appreciate that, and have a great day. Thank you. I'll see you later next week.